Hi, I'm Dr. Richard Geyer, orthopedic spine surgeon.
Hi, I'm Dr. Jack Zigler, orthopedic spine surgeon at Texas Back.
Hi, Dr. Scott Blumenthal, orthopedic spine surgeon, TBI. Today we're going to talk about disc replacement both in the cervical and lumbar regions and hopefully answer questions that you might have and be informative.
An artificial disc is much like a hip or knee joint made out of metal and plastic, in which we actually remove the diseased disc and put a moving joint in there so that the patient doesn't have to have a fusion.
Discs are spacers in between the bones that are the building blocks of our spine, and sometimes they'll wear out, and they can wear out and pinch a nerve, or they can wear out and become a bad, painful shock absorber. And a disc replacement lets us take out the damaged disc and put something in that's not going to stiffen up the spine like a fusion. So it's been a very exciting new technology for us in the last 20 years.
And more importantly, for these degenerative discs, much like if you had a diseased hip or knee, you would never go to an orthopedic surgeon and have them tell you that you need a fusion. So now we have that ability in our spine patients to say, no, you don't need a fusion, but we can do a disc replacement and return your motion to normal.
And I can't tell you how many times I've been told by patients that this is a lifestyle-saving procedure. It makes a huge difference in people's lives.
The advantage of doing disc replacement rather than a fusion is that we can preserve motion or carry out a motion preservation operation in either the neck or the low back, which is a huge benefit to the patient. We know that fusions will cause the next level up to degenerate, and now we have good 10-year data that shows that the chance of this occurring after disc replacement is about 1/3 to 1/4 the chance compared to if you had a fusion.
And the advantage to preserving motion is faster rehabilitation, return to a more normal range of motion, and as Dr. Geyer said, we know that in the long term it helps the rest of the spine age more normally rather than abnormally.
But don't you also think that the way that we have to put these discs in, which is surgery from the front of the spine, anterior spine surgery, is part of that recovery? Because at least in my experience, patients recover better from surgery from the front of the spine. Even if a fusion is necessary, the front of the spine tends to recover quicker and with less pain than the traditional spine surgery, which has always been done in the back.
Well, and that brings up a good point, because we use a minimally invasive approach. We're not violating the normal tissue planes, and that's why patients are discharged the day after surgery and begin carrying out relatively normal activities right away.
We usually get our patients up within hours of their surgery, and most people go home within 23 to 24 hours. So it's unusual when people have to stay in the hospital longer. But if we look at our patients, the recovery pattern of patients who have disc replacement is always much better than the recovery pattern of patients who have a fusion. It's faster, it's more natural. At 2 weeks when people come back in the office, you almost can't tell that they've had surgery.
Yeah, the reason I think anterior approach is better for the patient is, as we said, there's relatively no disruption to the normal tissue. You basically kind of moving stuff out of the way, getting the spine surgery done without bleeding, without muscle damage, and with a relatively or less painful place in the body.
Yeah, even the lesser invasive techniques going through the posterior muscles are more painful for patients. And typically, that's what patients really complain about more than their anterior discomfort is the muscle discomfort from behind, even if it's a small incision.
Well, the ideal patient for a cervical disc replacement is one that over the years has typically received a fusion, and that would be a disc that's displaced, ruptured, bulged, there's many words for it, and it's hitting a nerve. And they've got severe neck and or arm pain, and they've tried some other stuff conservatively. If they have weakness, we tend to be a little bit more aggressive with it, but that's kind of the ideal patient. And it can be done at more than one level.
It's primarily someone that has arm pain that doesn't get better after 6 weeks typically of non-operative treatment, sometimes longer, rarely shorter unless there's some progression that requires you to intervene quicker. But usually people come in because they've got arm pain and then find out that it's coming from their neck.
And the other thing, as pertains to total disc replacement in the neck, is if a patient's had a fusion previously and has another ruptured disc, it's a great operation for them. Just because you've had a fusion in the neck doesn't mean you can't have an artificial disc next to it.
And there are some reasons why patients have to have a fusion, but we think any patient who's been told that they need a fusion owes it to themselves to at least get an opinion as to whether they're a potential candidate for disc replacement.
And that goes also for the lumbar spine. When they've been told they need a fusion, a lot of them are candidates for a disc replacement.
Now, lumbar disc replacement is a different animal. It's mostly done for mechanical back pain when the disc wears out as a shock absorber. And those patients usually have back pain that fails to get better for 6 months or so of conservative treatment. And traditionally, they've been offered a fusion, and we got very good results with our fusions because we selected our patients well. But disc replacements, again, allow patients a faster recovery, maintain motion, and better protection for the rest of their spine.
And the results are just astounding. All of us have stories that patients come back, "Doc, you changed my life." And this is what keeps us going. This is why we've devoted almost 2 decades of our career for disc replacement. And the results are really paying off. It's frustrating because, as you said earlier, Jack, that most patients, a lot of docs don't even recommend disc replacement. And there's a number of reasons for it, but we see the results. We have long-term follow-up. Our first 1,700 patients, we had a 1% revision rate. People think, oh, they fall apart, they go bad. Surprisingly, they do great.
It always bothered me to do a fusion because we were changing the mechanics of the spine. We were taking something that was made to move and now stiffening it up. It was a good trade-off if the problem was causing the patient a difficulty in their life, and we could give them less pain and take the stiff segment but move on with their life. It seemed reasonable. But now we have an alternative to take out the painful segment but put in something that allows the spine to continue to move and helps protect it. So for me, it was like an epiphany in my career because it allowed me to do the surgery without having to compromise the patient's mobility.
It didn't make sense to me, and at the time we were talking among ourselves saying that, they do total hips and total knees, why not an artificial disc? And that's when we at TBI embarked on our our disc replacement journey, and we sent a group of researchers over to Germany to see what they were doing, and then the rest was history, and we did our first disc in 2000 and haven't stopped. And I think this motion preservation with the total disc arthroplasty has been such a boon for the patient. And although we have a lot of patients that are undergoing these big scoliosis fusions, it's good, but patients have problems after a number of years at the ends of where they're fused. So although we are pioneers in an area, I think as time goes on, more and more people will realize the benefits of motion preservation, even in some of these other areas that we don't do.
Yeah, from the first day that I started practice, patients would ask, why you recommend a fusion? Why can't you just replace the disc? And I would say, that's a good idea. Maybe someday that technology will exist. But I never realized or imagined that we would be the ones to bring it to the United States and to pioneer it. And so that was the life-changing, for me, part of my career, is to see something pie in the sky and then to be part of a team that made it happen.
The M6 is one of the first discs that allows shock absorption. So all the other discs that we have to use in the US now are motion machines. They're either a ball and socket or something like that that allows motion, but they're not good shock absorbers. The M6 is designed more like a normal disc. It has components to it that are very similar to what's in a healthy normal disc. So it's the best we can do towards restoring the same kind of anatomy that we've taken out or that has become broken. So it's exciting for us because it's a new way of helping a patient recover that additional force transmission.
And it's really the 3rd generation disc that we have now. And short of designing a biologic disc that we can grow and culture and transplant into a patient, this is the best thing that we have today.
Yeah, for years, just because it was so commonly done outside the US, and patients got on the internet and said, hey, I want the M6, and we couldn't do it because it hadn't been FDA approved yet. Now that it's FDA approved, it's just another thing that we can offer as a really good alternative to the patients.
And it's been one of the most successful discs outside of the US with over 50,000 being implanted. 50,000, can you imagine? I think that the satisfaction we get out of doing disc replacement is having the patients come back and say, "Doc, you gave me my life back." But one patient I remember in particular was about a 35-year-old gal that had chronic low back pain for 10 years. She's from Alaska. She had 4 little boys and literally couldn't do anything. We had done a 3-level lumbar disc replacement on her, and she sent me her 1-year x-rays, and she wrote a beautiful letter and just stating that it's the first time in 10 years that she was able to do this and that, and she showed pictures of her rock climbing and with her kids going on a hike and her skiing, and it was very, very touching. In fact, I read it, I almost got teary-eyed, and I showed it to some of the people in the office, and they said, "God, that really touched it." But that's what it's all about, and we've all had patients like that, but she in particular I'll always remember.
We all have memorable patients, and for me it's some of the younger patients that we've done disc replacements on because it's a difficult decision. The patients and their parents always want to know what's the longevity. Will this last for a long time? And we honestly tell them we don't know. They haven't been around that long for us to really put a long number. We know that in testing in the labs that they should last for 40 years or more. But I do know that if we have to do a fusion on someone who is 19 or 20 or 22 or 24 years old, that there's a price to pay for them in 10 or 15 years that we don't anticipate them having to pay with an artificial disc. So even if in 30 or 40 years there are issues that develop that are unknown today, they've still enjoyed the benefit through their very productive years of a lesser chance that they're going to break down at adjacent levels. So those are some of the best patients. Remember a patient who was barely able to finish school and had to be homeschooled the last year because they couldn't go to school and sit. And their life was about to be derailed because of their back pain. A disc replacement allowed that person to go on to college, to go on to law school, and I get letters every year because she's now a successful attorney on the East Coast, and her life was changed dramatically by our ability to do a disc replacement for a young person.
Yeah, I've had a couple, again, young patients that had discectomies in their teens and were really perfect candidates for disc replacement in the lumbar, low back, but had to wait till they were 18 because that was the FDA trial. And one in particular had the disc replacement, did marvelously, and I was buzzing through clinic a week or two ago, and she was shadowing Rick as a pre-med student in her summer vacation this summer, so that's a pretty cool thing.
Well, we've always taken pride in the research that we've done, and we've participated in about 14 FDA trials of the artificial disc, and that gives us great confidence that what we're doing is offering the patient the best possible care. And the FDA system, although it's a little arduous and a little slower than what we have outside of the US, it still is important because it's for patient safety.
But we've been able to participate in lots of studies from the beginning, following patients through several years. We've all been fortunate to have been authors of some of the most important papers in disc replacement that have been published, and then follow those patients out for much longer term. So when it comes down to where the rubber meets the road, talking to a patient one-on-one, we have the confidence to be able to say that we've done over 3,000 disc replacements in the last 20 years, and we've followed our patients, but we've also participated in these multi-center studies, so we've followed patients from all over the country, and that compares with patients who are being followed all over the world. So we can give patients a much better idea of what they can expect based on that very large number, even though it's a decision that really just comes down to the patient and a doctor.
And Jack, something you said before was interesting because you said in the beginning we didn't know how long they would last. And I remember when we started in the early 2000s, we told patients if they got 10 years of good motion, that was good. But what we're seeing is that they're continuing to do well, and even the long-term studies and the recent 10-year PRODIS study showed that the patients continue to do great. And even our early Charité, which is the first generation artificial disc, I still see those patients back, and I know you do as well, Scott, because we participate in the study. They continue to do well. We're not seeing the wear. We're not seeing these horrible complications. So now we can tell patients we've been doing them 19 years and they're still not wearing out.
And the research continues because, particularly, let me give an example. In the lumbar spine, the companies paid for the research to get approval for a lumbar disc. But the payers, the insurers, will only approve one lumbar disc. So we fund our own research on looking at a lumbar disc next to a fusion called a hybrid, or multi-level lumbar discs. So that hopefully can be a game changer as well and move the needle so that eventually U.S. patients can get coverage for extended uses, not just the original FDA studies.
You know, I'm particularly proud of what the three of us have done because we truly have been the pioneers. We started, 20 years ago in this journey, and we continue to do so. And we're not like, some groups where they just jump on and they do some disc and find out it's bad and then they jump off. So we've been around the block a time or two, and I think we offer our patients the best possible care. We have great access surgeons, which are the people that get us to the front of the spine for the lumbar. And we really do our patients well, I think. We have a great program where patients will send all their information in, and we have our staff that will coordinate their visit, make certain they have all the tests. And post-operatively, we also coordinate their follow-up care by making certain they get the right rehab, by making sure they get the right x-rays, and we do telemedicine follow-ups in many cases. We don't require out-of-town patients necessarily come in, although we would love them to come in. I would say most of our out-of-town patients just send in their x-rays and we talk on the phone and see how they're doing. With electronic media today, they can take pictures if they're worried about their wound or whatever. And fortunately, because we are so good at what we do, we rarely have any patients that have to come back in for follow-up.
But unlike going to Europe, we take care of our patients post-operatively. If they do have a complication, they're in the United States. The one complaint I've heard about patients going to Europe is, yeah, I had some problems, but I tried to contact them, I never heard back. Fact of the matter is our experience now has caught up or surpassed the European centers where people thought they had to go to get, off-label or extended or multi-level or hybrid, and now they can come here because we've done all that.
No matter what surgery you need, but particularly newer technology, I think you want to go someplace where it's done a lot and the results are good, and you have a good feeling dealing with the surgeon and staff. And hopefully that's what we provide. We've worked very hard at it, and the people who work at TBI have worked very hard at that as well.
And in addition to our travel program, also the hospital that we work at, they treat them so well that patients typically say, from the second I walked in your office to the time I was discharged from the hospital, everybody was terrific, and everybody treated me like, I was their family and gave me the best possible care. And that's very gratifying.
We've watched insurance coverage change for artificial disc replacement, and the good news is that cervical reimbursement has gotten much, much easier. Almost every insurance company now will cover 1 and 2 level cervical disc replacement, although you have to fit within their medical policy criteria. And we're pretty familiar with the different policies, so we can be helpful in that way. The frustration for all of us has been lumbar coverage, which has remained much less than we'd like to see. There's been some movement in the last few years, but there are still about half the insurance companies that don't approve lumbar disc replacement. So patients get very frustrated. We share that, and we can be as helpful as we can, but the buck really stops with the insurance company policy.
And I found that patients that are more active in their care, and it's sort of like the squeaky wheel gets oiled, occasionally we'll get some funny coverage claims where they'll cover 2 levels, or they'll have a policy where they say absolutely not, and the patient will get involved and through the HR, and if they're self-insured, sometimes those patients we can help get approved.
But because we work so closely with our hospital, we've been able to offer a cash bundle for people who can't get insurance approval. And nobody wants to come out of pocket to pay for health care when they've been paying for insurance premiums. We understand that, but for patients who are not going to get covered through insurance, we at least can offer an affordable bundle that includes the disc and the surgeon's fees and the hospital fees all together in a facility that gets it done very well.
And the prices are very competitive with Europe.
Yeah.
Well, we want to thank you for listening, and hopefully we answered a lot of questions that you might have had about disc replacement. If you have any further questions, please contact us at thecenterfordiscreplacement.com.